All right, welcome back. Part 2 of infrequently used ED drugs that you probably ought to know about. Anybody ever use octreotide? Octreotide, ever use that thing? This in the States is called Sandostatin as the trade name, but octreotide. So this is a hormone that inhibits stuff. It inhibits growth hormone, probably not a necessity to use that in the emergency department setting. You know, emergency growth spurt, somebody's having, going to go take care of that. Inhibits glucagon. Well, we already talked about some reasons we may use it. The real reason it's used in the emergency department is because it inhibits insulin. And then lastly, it has a lot to do with decreasing blood flow to the stomach and GI tract. So it's used in GI bleeding. So our two main reasons to use this stuff is hypoglycemia associated with the overdoses of the sulfonylureas. That's the first 4 papers there. They make the point that somebody overdoses or accidentally it takes too much sulfonylurea, you start giving them IV sugar, IV sugar, IV sugar, IV sugar, and that basically causes the pancreas to make out insulin, insulin, insulin. So you have this phenomenon where you can get spells of hypoglycemia throughout the treatment of these cases. They talk about what they call rebound hypoglycemia, and papers 2, 3, and 4 all talk about its use in that setting where infusions alone are not doing it, and that it lasts about 8 hours. They say, however, don't think because you're aware of this drug that you can give it, and people who are hypoglycemic because of this drug, because of sulfonylureas, can go home. So the mantra that they have to be admitted is still probably true. How many of you have routinely used this stuff in this case? So it's pretty well known, maybe half of you. So, and it's not like an experimental kind of thing. It does work. 8 hours is the duration, and so says papers number 3. Number 4 is this series of cases, 9 case studies. Episodes of hypoglycemia decreased from a mean of 2.9 to 0.2 once octreotide was started. That's good. And then they point out 2 episodes of recurrent hypoglycemia occurred with this drug at 14 and 36 hours, implying that it doesn't last forever and that you therefore still have to have them in the hospital and may need to give this stuff every 8 hours or thereabouts. The second use for this drug is in the treatment of upper GI bleeding of any cause. If the idea is that this will decrease blood flow to the stomach and GI tract for some period of time, whether it be stomach, variceal bleeding, ulcers, gastritis, whatever, this drug would be used in that setting. Number 5 is a extensive literature review. Meta-analysis of 14 trials, 1,800 people. The relative risk reduction associated with using this drug with regard to continued bleeding and rebleeding was 0.5. Number needed to treat is 5, which is considered to be pretty good. It decreased the need for surgery, relative risk reduction by about 30%. And this drug is not somatostatin, but it is very similar to it in terms of number 6 is the strongest paper here. And it basically says, octreotide is more potent than somatostatin and lasts longer. Compared the treatment with octreotide and ranitidine. This is a really kind of bogus study, because every study that looks at you have a GI bleeder due to a peptic ulcer disease, you compare a ranitidine or a H2 blocker with a proton pump inhibitor, and every one of those papers that do it say ranitidine and the proton pump, and the H2 blockers really didn't do very much at all in terms of controlling rebleeding, amount of bleeding, necessity for operations, etc. in those cases. This doesn't work. If you're going to use anything in a GI bleeder, you would use a proton pump inhibitor, because the preponderance of the literature says it is somewhat helpful. Certainly not a slam dunk, oh my God, yes, absolutely helpful, somewhat helpful. So they compared octreotide here with something that's been shown not to help in the setting of peptic ulcer disease. 84 adults, hematemesis due to ulcers, hemostasis with octreotide, 83%, 55% with ranitidine, blood transfusion, 250 ml versus 1,000 ml average. Endoscopic therapy or surgery, 17% got either one of those when they gave the treatment versus 40% when they didn't, or when they gave ranitidine, which is the same as no treatment. No apparent adverse effects with octreotide in the setting, so that was considered to be a very positive study. 7 is a negative study on it. Not all of these studies are uniformly positive. It's not like the same literature talking about this drug in the setting of hypoglycemia where everybody acknowledges that it can be beneficial. Sometimes these papers are not particularly positive. Number 8 is a positive paper. Octreotide, they said, it's been reported to be one of the alternatives to putting something down in the stomach that will decrease or in the bloodstream that will decrease blood flow, like somatostatin. Octreotide is a vasopressin, or a cousin of vasopressin, terlipressin. Obviously, these are vasoconstrictors. So here's a little comparison. They compared in this study emergency sclerotherapy in people with varices, nasty bleeding. Emergency sclerotherapy was one side versus octreotide on the other side. 98 people, variceal hemorrhages. Initial control bleeding, 90% with sclerotherapy, which is considered to be kind of the definitive treatment, versus 84% with octreotide. That was pretty good. Rebleeding, transfusion requirements, duration of hospitalization, and mortality rates were similar in the two groups, so suggesting, again, quite positive. Side effects of octreotide limited to nausea in 5 patients, while 18 patients managed with sclerotherapy had other things happen, like fever, chest pain, pleural effusion, aspiration, pneumonia, and other not so good things. So, anybody ever use this in the setting of a GI bleeder, octreotide? They're pretty common. Some reasonable evidence that it would be working and not too harmful in the side effect profile. That's good. And the last drug here, magnesium. Underappreciated drug in the emergency department setting. So this vital electrolyte, I have no idea why we don't measure magnesium. We measure everything else, but we don't measure magnesium. We even measure chloride, which is a total waste of time. You're already measuring the sodium. You want to measure, it's like belt and suspenders. I mean, you don't need to measure both. If you measure the sodium, you don't need to measure the chloride, yet we measure the chloride. How many times do you see a different, the sodium's 160, the chloride's only 100, It doesn't happen. It's called sodium chloride. They go together. Let's get rid of that chloride and stick in there that magnesium. They say, well, it's an intracellular ion, and therefore it may not be what you measure in the serum may not reflect the intracellular. Well, you can say the identical thing about potassium. 30 times more potassium in the cell, we still measure it. And if it's low, if it's 3.2 or 3 or 2.8, we consider that worthy of supplementation. Yeah, maybe not 100%, but I don't understand it. And in fact, some studies say that magnesium and potassium are like brother and sister. I mean, they go hand in hand. And some studies have basically shown you are low on potassium. One of the ways to facilitate your getting your potassium intracellularly back where it's supposed to be is you give potassium and magnesium together in those settings. So first is asthma. IV magnesium has been tried in asthma, and nebulized magnesium has been tried in asthma. There's a big review here, number 9, from the Emergency Medicine Journal. This is 15 trials of IV mag involving 1,100 people and 9 trials of inhaled mag, 532 people. And this trial, basically, this summary of all of these studies basically said, IV mag, a relatively weak but statistically significant effect on pulmonary function in adults, but no significant decrease in the number of admissions in adults. So little effect that could be measured by pulmonary function tests. What about kids? Both respiratory function and hospital admissions were both improved with IV mag. The relative risk reduction is 0.7, so a 30% decrease, which is pretty substantial. If you get into this literature yourself and start looking at the papers, one of the things that you find is a lot of papers say it makes no difference. And one of the key differentiators in these papers is how bad the asthma is. if you have a really mild or moderate case of asthma, adrenergics work so well that it's very difficult to tease out the incremental benefit done by any other drug, whether it be an atropine-related drug or magnesium or ketamine or anything, because they're doing so well with the adrenergics alone. So the differentiator is that the cases that are really, really severe of asthma, where their life is on the line, if the baby intubation, those kinds, you may be able to see an incremental difference in those cases. And I think that's more consistent with the literature. Now, this is not a slam dunk miracle drug in that setting, but if you can prevent somebody from being intubated who has a bad case of asthma, you've done them a big favor. So I think that there's absolutely no reason not to give somebody who's really huffing and puffing 2 grams of mag. What the downside will be, they'll get a little flushed feeling, it'll feel warm and cozy for a while, that will be it. And maybe they'll get some vasodilatation from this. Well, not vasodilatation, they will get vasodilatation, that's why they're flushing, but there may be their airways will also dilate up a bit. That should be a good thing. Magnesium and COPD is addressed by number 13, randomized controlled double-blind. Now, obviously, COPD is not quite as clear-cut as asthma in terms of bronchospasm, but most people have some element of bronchospasm when they COPD. So 72 VA patients with an exacerbation, unresponsive to 2.5 milligrams of albuterol. So the question there is 2.5 milligrams of albuterol might be not enough, or maybe these are not people who have much in the way of a bronchospastic component. But be that as it may, they gave these poor souls on serial assessment for 45 minutes. They gave them some IV mag, a modest beneficial effect on bronchodilation. At 45 minutes, as an example, the peak flow had improved 22% with mag, 6% without. 22%, 6%. Seems like it's a fairly reasonable improvement, nothing remarkable. Hospital admissions, 28% with mag, 42% without mag. 28 and 42%. Not statistically significant, but certainly looked like a trend in the right direction for mag in these cases. So I think it's a reasonable thing to use. It's not a miracle drug, but it may make some incremental benefit, which may prevent some much more drastic action being taken. 14 to 25 talk about its use in arrhythmias. The first group of papers is on supraventricular arrhythmias. And number 14 talks about how it works in COPD patients with multifocal atrial tachycardia, which I was taught basically was a aminophylline toxic rhythm in COPDers. It was unique to COPDers because they were the people who get all the aminophylline, which was driving all of this cyclic AMP from being disintegrated and causing them to have multifocal atrial tachycardia. And they were randomized to IV mag or placebo. Well, that's not exactly fair because you're not going to use placebo, but it clearly shows that it has some effect in these cases. By 5 hours, the rate of these patients who had the multifocal tachycardia went from 130 to 99 with mag, but not in the controls. And at some time, 7 of the 9 mag patients returned to sinus rhythm, and at 5 hours, it says, 4 of the 9 had converted to sinus rhythm. So it's good. Magosulfate is considered, I think, one of the drug of choice for multifocal atrial tachycardia, should you see it anymore. Number 15 this is kind of interesting. This is mag versus the amiodarone, the big gun, stops everything known to man. 42 critically ill patients. Mag was more effective in conversion, 60% at 4 hours versus 45% with amiodarone. And at 12 to 24 hours, it was 70 to 80% of the people getting mag versus 50% of the people getting amiodarone. So, it's not, in these arrhythmia cases, it isn't the poor second cousin. In the asthma cases, it might add a little incremental benefit in the bad cases. In these cases, it basically shows it's as good as some of the standard things that are being used. We don't have to apologize for using it. Doctor? Actually, some papers measure the magnesium levels, many of them do, and it appears that it's irrelevant in terms of the efficacy. Yes, a certain paper, we're going to get into the ventricular arrhythmias in the CHF patients. And many of those patients, because they're all on diuretics, are low in MAG. But you'll look at some of these other papers, it says this effect was independent of what their MAG levels were. And so that's one of the reasons people say you don't need to measure it, because it doesn't matter. If you give 1 or 2 grams of this stuff, it's not going to hurt anybody, kind of thing. But you certainly would like to know if somebody's chronically low in MAG, because we'll talk about a group of people who I wouldn't know. I don't know why most of them in the population would not be on MAG every day. But we'll get to those in a second. So 14 and 50 are the supraventricular arrhythmias. 16 is a winner. 476 patients, so no small number of cases here. They had AFib. Now everybody wants to slow down AFib kind of thing. They're going to use things like verapamil and diltiazem to slow it down. They might use amiodarone, and in this study they threw in some placebo arm as this as well. A lot of cases of AFib. Better rate control and more conversions occurred with MAG than any of those other things, even amiodarone. 86% had rhythm conversion or rate control with MAG versus 56% treated with all of those other agents, those active agents. Response was quicker with MAG. Serum MAG levels did not influence the response. Major adverse events, 6% with MAG, 9% with the other drugs. So it was faster, safer, more efficacious than all of those things that we would routinely use. Now there's a couple of papers in here that talk about MAG plus digoxin, or digoxin alone for atrial fibrillation. Now, I don't know that many people use dig anymore for that. The 17 is an Australian study. Now you don't use MAG anymore for, digoxin for, no. Well, when was 17 published? Can you see in that book there? Is that an old paper? Oh, what's the story? That's not that old now. Some of your colleagues down there, some of the blokes is maybe using this. But in any way, whenever they added MAG to dig, the effect was better than dig alone. That was 17, I think it was 18 as well. 19 is another positive paper. They're all positive. And it's not going to, and I think that it basically says we can use this drug more effectively. It'll supplement others, and we could use it as a first-line drug. So those are the atrial arrhythmias. The next, 21 to 25, is the ventriculars. These are the ones that kind of scare you. And you'll notice that 21, 22, and 23 are all CHF patients. Yes. CHF patients drop dead. They have a high mortality in terms of sudden death. And their mortality is, if you had a choice between picking CHF and cancer in terms of your mortality, pick cancer. You will live longer if you have cancer than if you have CHF. And the major cause of death is ventricular arrhythmias. And look at some of these cases here. This is really pretty impressive. Like 21, this is 30 cases, no big deal. Class 2 to 4, CHF, New York Heart Association, left ventricular ejection fraction less than 40%. They looked at the effects of placebo and infusions of MAG in these cases to decrease their PVCs. There was a 53% decrease in PVCs with MAG, a 76% decrease in couplets, 2 in a row, and a 69% decrease in VTAC episodes. No significant adverse effects. These effects were, you have to acknowledge, were really pretty dramatic. Now the real skeptics in the room will say, well, does decreasing the PVCs or couplets or VTAC decrease your risk of sudden death? And some people would argue that it doesn't. All things considered, I'd like to have fewer. Thank you very much. 22, similar, looked at CHF with low MAG levels. So all these people are taking Lasix. All these people are being depleted of their potassium. All these people, I don't know that it's appreciated as much, but all of these diuretics deplete you of potassium, also deplete you of magnesium. So you're down one that you know and one that you don't know. PVCs decreased from 794, to 369 on 6 hours of monitoring the patients having the most PVCs. This is 300 PVCs an hour. Couplets decreased from 233 to 84, and in 22 patients with baseline episodes of VTAC, it decreased from 24 episodes of VTAC per hour to 9 per hour. So all of those things I would think is good. And then lastly, the 23s, hypomagnesemia and heart failure with ventricular arrhythmias, Polish study. Low MAG is common in CHF patients, that's for sure. Most are treated with diuretics. 38% in this Polish study had low MAG, 15% had low K.
It would be interesting to see what happens these days when we're using so many more beta blockers as part of heart failure treatment.
When they use beta blockers in the heart failure treatment,
As opposed to the 90s
yeah, it would be interesting. You would think that that would suppress these as well. But that doesn't mean that the beta blocker patients, as long as they have decent kidney function, can't take a slow MAG once or twice a day kind of thing as part of their handful of pills that they're going to be taking. It would seem to be, you have to tell me why not, rather than tell me why, that you would not do that kind of thing. If your kidneys are working, it will excrete the excess, so you can't screw this up kind of thing. You're not going to make somebody MAG toxic, but you're certainly going to make sure that they have been adequately saturated with MAG. You will retain your MAG and you won't pee it out until you're saturated. And there have been studies suggesting that a lot of, not only patients who have congestive heart failure, but a lot of angina patients are MAG depleted as well. And they give them IV infusions of MAG, watch what they pee out, and they don't pee out stuff for a long time until they become saturated. They separate the angina patients from the non-angina patients. The angina patients retain MAG because they're depleted. The non-angina patients don't. So something to consider. And this is another paper that talked about decreasing couplets, decreasing sustained VTAC episodes, decreasing PVCs as well. And you don't hear very much about this at all in terms of the literature or routine therapy for CHF patients, yet we see them every day, and virtually none of them come in on any kind of supplemental magnesium, and virtually all of them are on diuretics. They're all subjected to this issue of sudden death. So it seems to be, I don't know, maybe underappreciated. I know of no reason not to do this. No reason not to do this. Stuff is cheap, and maybe that's the problem. We need something expensive. You make this stuff expensive, they'll make ads in the journals, and then we'll use it. MAG for torsades is, that's the drug of choice if you have somebody who's having this who is awake and talking kind of thing. 3 cases are discussed in 24, and 25 is MAG for sustained monomorphic VTAC. 11 hemodynamically stable cases, failing other drugs. 3 of 11 were hypomagnesemic, there you go. 7 of 11 converted within 10 minutes. Only side effects were flushing. That's pretty impressive, I think. And then MAG for some other things. 26, magnesium increases the rate of hypothermia via surface cooling and improves comfort. This is about anti-shivering, vasodilatory properties. MAG in these volunteers hasten cooling and improve comfort. In the study that we talked about where we're trying to get more people to use cooling in the people who have had cardiac arrests, they get their blood pressure and pulse back, but they remain comatose. This is a volunteer study, but you would think that if it's going to cause vasodilatation, that it would facilitate cooling anyway. We're not going to do 27 to 30 because there's another talk about headaches and everything you could possibly think to use headaches. 31 says MAG in sickle cell crisis. Well, one paper, kind of hard to make a compelling case. And 32 talks about sudden hearing loss. Anybody treat any case of sudden hearing loss? Come in, I can't hear kind of thing. The definition of sudden hearing loss is hearing loss within 3 days. And the most common cause of sudden hearing loss in the emergency department is you got a cerumen impaction there, you have like a boulder in there or something like that. But if that's not the case and everything looks normal, then almost without doubt, the things that they do to try to treat these cases is to improve the blood supply by giving a vasodilator and decrease any kind of inflammation that may be involved in the eighth nerve in any kind of shape form. So the steroids, Vasodilators, and in this case, the vasodilator that they're using is magnesium. Prospective double-blind, 28 patients, which is a lot of patients when you think about how nobody's seen the really basically sudden hearing loss as an emergency. All got steroids, and half also got MAG or placebo. Wow, which is kind of a risky kind of business. Hearing improvement was much better with the people who got the MAG, so something to consider. Can't hurt may help. And everything that can't hurt may help, the threshold for using it would be pretty low, especially if it's something that you're not really particularly used to using and you're concerning side effects versus efficacy. Well, there's not much in the way of side effects here. Eclampsia, the 33 and 34 say, yeah, it's still the drug to use in eclampsia. It's hard to believe that they don't have a better drug for this, but that's what they use. Alcoholics is kind of interesting. That's 36. They say alcoholics got depressed levels of magnesium. Alcohol is a diuretic. They're peeing a lot kind of thing. And 40 chronic alcohol. These are chronic now. Were treated for 6 weeks with oral MAG, decreased in their muscular strength was better, their electrolytes were better, their enzymes were better, their sex life was better. Everything was better. You take a little magnesium. People take slow mag. They sell that at any drugstore kind of thing with the idea that it decreases. One of the side effects of MAG is diarrhea. And you take too much and you got a problem kind of thing here. And some of the people, before slow MAG came out, they would take things like milk of magnesia in subdiarrheal doses kind of thing. You know, you take it, try it for a couple of days, and find the dose that's causing diarrhea, then you back off 1 or 2 tablets, and that was the poor man's way of taking magnesium very inexpensively. All right, any comments, questions, disagreements? Peter?
Rick, 2 things. You didn't mention thiamine for failure. Do you have any understanding of why congestive failure is viewed by the feds as one of those ailments that's easy to treat and discharge from the emergency department?
Congestive heart failure is Medicare in the United States' most expensive diagnosis. It is by far the most expensive thing because of all of these coming back in and out to the hospital over and over again. So they are concerned about it and trying to optimize it to some degree. What was more specifically the question?
So the thing about thiamine is a bunch of articles.
Wet and dry, bury kind of thing, thiamine. We just did I think we're about to do a paper where it talked about this routine knee-jerk, every alcoholic gets the vitamin bag. The vast majority of alcoholics are not depleted in anything except the idea of giving them thiamine. So you can give them a little thiamine, that's it. But all of this making it looks like we're giving you back your urine. You know, it's going to freak them out kind of thing, you know. But it's just done routinely. It's probably not a big deal. But in terms of evidence-based medicine, it's often very difficult to defend. No harm, no foul, though.